I'm going to talk to you a little bit about advances in resuscitation. Now, I'm going to put my phone on silent because my hospital continues to call me if there's somebody in resus. So, so let's just start off. Advances in resuscitation. Are there any? For the last 10 years, I've been giving talks on resuscitation. And about 9 years ago, we predicted a lot of paradigm shift that's now happening. And I foresee that this decade will see a significant change in what's coming out in resuscitation. And I'll show you some of the literature towards the end. But let's just recap. I put this photo up all the time. This is the phone that we had when the Resuscitation Guidelines came out. Pretty fancy, right? Pretty fancy. This is the phone many of you have today. Right? So if a phone was still the Resuscitation Guidelines, this is the phone we'd still have. What's happened to the Resus Guidelines? We've changed the rate of compression. We've said adrenaline, maybe not adrenaline, maybe high dose adrenaline, maybe adrenaline again, maybe give it early, maybe give it later. We said, let's give lignocaine, let's not give lignocaine, let's give beryllium, let's take beryllium away, let's give amiodarone. Lignocaine has just come back in again, you can give lignocaine. This is the problem. We need a total paradigm shift because what we're doing is just rehashing the old stuff. Let's have a little bit of a look at that old stuff. Perhaps the only way we're going to survive is if we're in a movie.
It's all over. I'm sorry.
No pulse.
No! No, she has a strong heart. She wants to live. Come on, ladies. Come on, baby.
That's what I do in resus every time.
Von's been poisoned. He's going into cardiac arrest.
This guy looks a bit
Attach
like
the
Ryan,
leads to your
actually.
chest.
I'm just saying. Have you ever
Take a
put
blue
pads on
combi
a sweaty
bond,
patient like that and
mid-neck,
they stick on
into the
perfectly?
vein. That will counteract the digitalis. Push the red button now, Bond.
Come on, baby.
Zapper again. Do it!
Charge it.
Do it! Come on, breathe, baby. God damn it, breathe. Fight! Fight! Right now! Do it! Fight, God damn it! Fight! Fight! Fight!
Scared her back to life again.
Bond, push the damn button.
Do it now!
Oh. So the resuscitation rate in reality, 3%, 5%, 6%, 7%, 11% depending on where you are and what you read. 99.9% in the movies. If you're in Baywatch, it's 100%. Everybody survives on Baywatch. So, let's have a little look at a couple of things that we talked about. So, airway. We know that airway and resuscitation doesn't help. All the studies have been done. Cardiac arrest, we spoke about this yesterday, cardiac pulse. The studies that show that in hospital cardiac arrest, you try and intubate in the first 15 minutes, they have a worse outcome. Why? Because you usually interrupt CPR. We know that out of hospital cardiac arrest, all the studies have been done, Airway 2 trial, everything has been done. It shows us that supraglottic airway, endotracheal tube are non-superior to bag valve mask. Now, supraglottic airway may be helpful if you're trying to free up a pair of hands, but they are not superior, so don't try and intubate. Don't care about intubating. It's adult literature. What about pediatrics? 2 good studies have come out in the last year. One which is a meta-analysis and the other one which was a trial that shows exactly the same thing. There is no benefit to be gained from trying to put in an endotracheal tube. Bag valve mask. I put an endotracheal tube when I've got ROSC in my patients. Done. That's airway. Does positive pressure harm? In fact, some of the studies have now shown that positive pressure is a bad thing in resuscitation. So intubating and bagging them right up. What's the bagging rate usually in a resuscitation? They did the study on this in residence in the US. The average rate of bagging per minute was 52 bags a minute. Yeah? Your patient explodes after a little bit of time, right? What do the guidelines say? 8 or 10, because we know that the survival above that is 0 because you hyperinflate the patient. Does all positive pressure harm though? Because maybe some positive pressure is helpful. There's some devices that have come out, and we brought up the idea of using apneic oxygenation and resus. I discussed this in detail. Does apneic oxygenation work in resus? No, unless you've already primed the pump. If their functional residual capacity is at its maximum, if this is somebody that's been pre-oxygenated, leave the apneic oxygenation on. It may help us. But there's no great evidence on this. This is a Busenek device. This is a device that they've actually come up with that delivers oxygenation. There's this pointer again. There we go. It delivers oxygenation, but it's got a valve up the front that protects air escaping. So it gives you a little bit of positive pressure. This is actually in use in the States, and it's use in Europe, but not in Australia. What else have we got? We talked about pulse. Forget taking the pulse. Okay, we talked about this at length yesterday. I tricked people into trying to take my pulse, and they worked out that I don't have a radial pulse on one side. So forget about taking the pulse. The ATLS guidelines that tell us that a carotid pulse of 70 millimeters of mercury is rubbish. It's not real. Let's forget about that. What about Headup CPR? Headup CPR is a big thing that's come out, and the whole idea of Headup CPR is you sit your patient up so that you decrease your intracranial pressure. So you increase your perfusion. Studies are very early, but this is actually being used in the States at the moment with very, very good results. The problem is it has to have a mechanical device. We don't know the angle, maybe 30 degrees. We're not quite sure what we're doing with it. And what happens is that the angle of the heart or the position of the heart changes when you sit your patient up. But it's quite compelling when you look at the intracranial pressure monitoring on this, and the intracranial pressure drops significantly and the cerebral perfusion pressure increases significantly when we sit the patient up. And the biggest problem that we have in all of the studies, okay, all of the studies that have come out shows that advanced life support doesn't work because it doesn't give us increased better neurological outcomes. But this might. What else did we look at in the last year? We looked at using echo, and that's why we've gone really big with the echo, because it's very, very important. The field study was a pivotal study in my opinion. 30-something% of people that were in asystole actually had that coordinated cardiac motion on echo. Over half of the patients that were diagnosed with PA had coordinated cardiac motion. 3/4 of the patients, maybe 4/5 of the patients, had management change purely by using an echo. This is compelling stuff. We talked about some of this stuff on how to treat PEA and using an algorithmic approach based on narrow complexes versus wide complex, a study published by Littman. There's been another study produced a couple of years ago that rubbished this a little bit, but rather than remembering the H's and the T's, this might be a better way of going. What else did we talk about? We talked about shocking asystole, because we know that a percentage of our patients are not in asystole, but they're in VF, and we haven't picked it up because we haven't scanned the leads. Great case studies all over the place, case reports everywhere, but no big study, and there'll never be a big study on this. We talked about refractory VT-VF, we talked about catecholamine responses, we've talked about double sequential defibrillations. We've covered all of this year. But there's a lot of stuff there that we've covered in the last year in resuscitation. But today I want to look at the cool new stuff that's going to be happening out there, all right? I'm not going to talk about ECMO. Who here has ECMO? Right, and that's why I'm not going to talk about ECMO. Gadgets. This is the tricorder used in Star Trek by Dr. Bones to diagnose everything. All he'd do is pass the probe over and he'd tell you exactly what was going on. Now, the X Prize, they offered a $10 million prize to anybody that came up with something similar to tricorder, and Google was part of this as well. And there are some new devices that are starting to come out now. They're not there, but they're at least doing temperatures and blood pressures and heart rates and all of these things without being invasive by using some of this new technology. This is where a lot of the sort of Google funding in this health area is going at the moment. This is already here, tissue interrogation spectroscopy. We can actually interrogate mitochondria. We can see how much oxygen perfusion we have in our tissues or in each of our organs. That's there. I'm never going to get that in my little rural emergency department, I could tell you now, right? I'm having trouble getting an ultrasound machine in my department. Right? I actually had to buy my own ultrasound machine with my money for our department. This stuff here, the chain of survival, we know that CPR works, we know defibrillation works, but we need to get a defibrillator to people, and we know that we need to get it early. The studies have shown that only about 4% of people get a defibrillator if we're using a road car. So they're now starting to use drones, and that percentage has gone up to the 80s. But again, what are we doing? We're rehashing the old stuff. We're doing CPR and defibrillation, and we have one protocol that's good for everyone. Well, one size does not fit all. And this is where we have to start thinking about change now. Tailored resuscitation is going to be the catch cry of this decade. And tailored resuscitation starts to look at what happens to the physiology as we resuscitate a patient. And we talked a little bit about breaking ribs yesterday and what happens to the pump. Rather than become a forward pump, it becomes a sink. We get third spacing. All of this stuff changes. The optimum compression waveform changes over time. And the optimum compression waveform changes between veins and arteries. So one waveform doesn't fit everybody. And we know that blood pressure decays over a period of time. And the atrial pressures measured in these studies decrease during the resuscitation. So maybe pressors and fluids are better later in the resuscitation. We get third spacing and we get decreased pressure. There's some studies being done on that. The primary variable that impacts blood pressure is filling time, and a slower waveform into the resuscitation actually favours this. So what does that mean? Push hard and fast, but maybe slow down a little at some point. The new studies have shown that compression rates of up to 140 give you better results than the 100 we've been using. But you try maintaining 140 compressions. We know that our compression depth is going to decay. We know the effectiveness of our CPR is going to decay. So some of this stuff is coming out. But the most important stuff that we're starting to see is this thing called postconditioning. And postconditioning looks at what happens after cardiac arrest. So you started to get ATP generation is affected, so we can't get the energy out there into the tissues. And then when we start CPR and we provide oxygenation, because all that CPR does, all the blood flow does, is deliver oxygen to our tissues, really. That's what we're doing. There is a generation of reactive oxygen species, and we know that that's detrimental. And postconditioning is a way of reducing the perfusion or the reperfusion injury. And some of the studies are starting to show now that we should really be treating cardiac arrest in the later stages like we treat arrest in neonates, where we're building up the oxygenation. So we should be giving them a little bit of a break and stopping reperfusion injury. So all the animal models so far are showing really good results. In this one here, they, for example, 15 minutes of untreated VF, they had one group that had CPR and one group that had interruptions in CPR of 20 seconds. And there was significant improvement of left ventricular ejection fraction and neurological outcome. I don't know how you judge neurological outcome in a pig, but they really had great neurological outcome in these studies. But this is kind of cool stuff. But perhaps the coolest stuff that we're going to see, and it's already being used, is this. I presented this case yesterday, the lady that had SATs of 62%, nobody could get them up, and then she arrested. But what if I had said on the phone as I was coming back into the hospital, hey, listen, just give her 50 ml of IV oxygen. IV oxygen isn't new. It's been used in the 1800s. The problem is they used to just pump oxygen into the vessels and everybody would die from air embolisms, right? So let's be a little bit cleverer. So they're now starting to look at hyperbaric oxygen. Now, we know that in hyperbaric oxygen, we increase the pressure, we increase the amount of blood that's diffusing into the stream, right? And it doesn't cause damage. And they're using the idea of this Henry's law, where you can increase the pressure significantly and increase the amount of oxygen that you can dilute into a fluid, either by increasing the pressure or decreasing the temperature, and supersaturating that fluid. And this has already been done. And there are over 3 million people already treated in China with this. There's tons of studies out there. There's techniques at the moment for treating patients. This is a thorax. It's a system that's being used in Europe and getting FDA approval in the States, and it's used for perfusing hearts after they've had an infarct with great results. The studies on this are starting to come out. The first one came out in 2012. This is a pediatric intensivist at Boston who created a lipid effusion, basically. He used technology of microparticles that was already used by somebody else, brought it in and supersaturated those particles with oxygen. And he created this sort of lipid effusion now that in all animal models that have been done are showing spectacular results. So we're going to start seeing some significant changes in this decade. So in this first talk, I wanted to give you a little bit of a taste and to start to think and get everybody thinking about the fact we have to have a paradigm shift and stop thinking about things in the way we've always done them and start thinking about them a little bit differently. Thank you very much.